We are absolutely thrilled to have Sherry Quire, the Director of Organ Services at Indiana Donor Network, join us today and share her unique insights in the donor and transplant community. Sherry and her team are incredibly innovative and have brought the Indiana Donor Network to record-breaking organ donations and transplants. And we want to have a very special welcome to you, Sherry, and we love working with you, and we're thrilled that you're going to share your team's insights in working with us and all of the record-breaking transplantation and donors that you've been doing. So all yours. Thanks.
Okay, thank you. Okay, I have nothing to disclose. I'm going to start off with talking a little bit about Indiana Donor Network and our service area. So our Indiana Donor Network, we coordinate organ donation in 85 of the 92 counties in the Indiana area. The counties near Chicago, Cincinnati, and Louisville are served by other OPOs. We do have a DSA population of a little over 6.8 million with 4.2 million registered donors in our DSA. Last year in 2024, we saw a little over 6,300 organ referrals, and we do have 2 transplant centers here, Indiana University Health, who transplants hearts, lung, liver, pancreas, intestine, and kidney, and then Ascension St. Vincent with heart and kidney. Last year, our 2024 numbers were we had 509 organ donors, 1,388 organs transplanted, not counting pink islet, and that is saving over 1,200 lives of 1,216 lives saved in 2024. A little bit about our growth in organ donation, our total organ donors year over year. And I'm putting it up here since 2018 because, as I'll talk about in a few slides, that's when we started our partnership in the June of 2018 with CompuMed. So we've seen tremendous growth, 185% growth in organ donation since 2018. Our brain dead donors year over year, a little bit higher than what we've been in the past, but where we've seen most of our growth, which is what most of the country has also seen, is in our DCD donors, with it being 146% from 2022 in our DCD donation. Our percent of our DCD donors year over year has also increased. We are in 2025 right now sitting at around 58% DCD. In 2020, we're at 19% and 51% in 2024. Our organs transplanted 2019 to 2024, and this does include pink islet for research. Last year, we hit a record-breaking 1,526 organs transplanted, including those pancreas. So I want to talk a little bit about our partnership with CompuMed, and it started in 2018, and it started with a conversation actually with Lee and our offices here, and wanting to be able to get more organs transplanted by being able to give better imaging to surgeons in a better way and a faster time to be able to do that. So we started with PowerShare, and it was really our first ability to provide imaging to surgeons utilizing DICOM images at the time. We put the link into UNET, which was password protected. We got a lot of positive feedback from transplant centers for that initially, and again, this has been several years ago in 2018. And previously, these things were happening in non-secure texting of images, or which could present a HIPAA risk, or being able to send pictures and things like that that weren't live imaging or diagnostics. And then we also had teleradiology services that were available at the time. All of our donors at the time stayed at donor hospitals. We did not have our DCU. And so we had to have the ability to overcome some of the barriers with a centralized read. So some of the things that we were running into is, allocation requirements, getting that chest X-ray, and being able to have that read within 3 hours of the first offer. And we may be at a center that is in the middle of the night, and radiology is not reading that in a timely, time frame for us to be able to start allocation. And so, having a lot of delays, in those donor hospitals. And so we were able to, send those to teleradiology services to, an expert that is reading for the country. So that also provides consistency, but also provided with us knowing exactly when those results were going to come back and being able to stand by those results and being able to present those to UNET so that we could have that on record so we could start our allocation offers. Also, rereads due to inconsistency of reports or lack of volume for transplant cases, meaning that, in some of the smaller hospitals, as we talk about, that tail of hospitals where we do, a lot of donation, 40 to 50 hospitals across the state of Indiana, but really doing the bulk of the donation in the top 8 hospitals, which means the donor hospitals that only see a couple of cases a year, some inconsistency of reporting or wanting to, reread something or add something in that would include any issues that we would see or foresee for safety to make sure that we're safely transplanting the organs to be able to give us that information. So centralized donor management portal, this is kind of where we started, with CompuMed to be able to, provide the exams, have everything right in front of us, and be able to do that with ease. And that really maximizes the trust of being able to have this in one place, one link, being able to connect the surgeons and anyone evaluating those organs to every diagnostic that there is available. So then flip forward a couple of years to May of 2020 was when Indiana Donor Network, we started our donor ICU and recovery center. We started that right in the middle of COVID. In order to be able to really save donation, we started that in 32 days. The first ICU didn't look quite like this, but about 6 months later, we were able to open this second ICU. We now have 6 beds. We have CT, cardiac cath. Here's one of our ORs that you see, and there's a lot of things that we have added throughout the year. So we'll kind of look through some of this. So our in-house organ donors, since working with CompuMed, this is how many we have actually brought in-house. So brain dead donors in-house, we've done over 560 donors in-house, which means over 560 multiple direct connects, multiple ways that they've been able to work with us and grow with us. I will say, as the theme of this, and one of the quotes actually at the beginning of the video is, the partnership has been really sitting down together and finding out where our pain points are, where our barriers are for donation, how we can move forward and work together innovatively to really listen to what we needed and then trying to find a solution around that. So I would say that's really the theme of, some of what we're talking about today. So since that inception, this year we're around 95% that we're bringing in-house. Some of this is from the very beginning, transferred in-house, but over almost 82% of eligible donors in-house. We do not transfer from our transplant centers, so that's why there is not all that are eligible. We do have corner declines, a few family circumstances, and some instability that we've not transferred for. But this is another piece that really makes a difference with our in-house donors and really ties back to that relationship with CompuMed and how we're able to do so many serial exams and with confidence be able to have results read quickly. If you look at the orange bars in our in-house donor versus the in-hospital, which are the blue bars, we consistently show, and this is just 2025, and has been the same theme over the last several years, we get almost a whole organ more transplanted if we bring our donors in-house. And we can attribute that to a lot of different things, but mostly being able to immediately take care of that patient, immediately know what needs to be changed, ventilator-wise, a repeat chest x-ray, a repeat CT, a repeat echo, and then being able to show how that organ has been able to be recruited and really getting ready for transplant. And we wouldn't be able to do this without being able to have some of the things that we've been able to partner with CompuMed. So in 2020, we started the Direct Connect. So it was really the first use of Direct Connect for us, and it was directly connecting our own machines. So that was set up by CompuMed and a partnership with our IT department, working through, all of that with our machines, our chest x-rays, our portable chest x-ray, our CT, our cardiac cath. And really it became an ease of use for the staff as well. Our staff, we are super self-sufficient here at Indiana Donor Network, and our staff actually learned how to run the CT, run the cardiac cath. We do bring in Ascension physicians to actually perform the cardiac cath. We are doing all the assist. Our staff do the echoes and the chest X-rays. They do everything themselves. So it was very pertinent that they learned how to actually do this direct connect as well, which was so easy for our staff and something that automatically now happens through our machines. With that, also increase our teleradiology services because everything in-house from, like we had already talked about with portable chest X-ray, as well as CTs and cardiac caths are read teleradiology-wise. So it's quick turnaround times. And we'll talk a little bit about how much we've done this and our turnaround times at the end of this presentation. It allows for multiple diagnostics, allows for feedback for new staff, which has been huge, especially when we look through with the echo training that we've done. So portable chest X-ray, that was in 2020. We directly connected that through a PowerShare link for PowerShare. With the first full-time use of it was teleradiology in-house with our chest X-ray, and we were able to send that also to our pulmonologist and medical director so they could also see immediately, as well. In 2021 and 2022, in-house diagnostics changed a little bit, and that's when we did the direct connect for the CT and the cardiac cath. Also set up by CompuMed and IT, and really an easy use for the staff. Really the same thing with a quick turnaround times, allowing for multiple, diagnostics. And we did have good feedback for the team too. This is the first time of them performing CTs. So if there was good feedback on CT, if they needed to re-CT the donor, they were able to do that and do that pretty quickly. This is our CT that is in adjacent to our ICU. And this is our cardiac cath that we have in-house. It's a Siemens RT's floor. Siemens both did the education for our staff. We average about 6 to 10 cardiac caths per month. And it really gives us the ability to transport our donors right away after authorization or disclosure. We were having to wait if they needed a cardiac cath until that could be performed, which, as you all know, there are certain things that you need to do before you can get a cardiac cath and make sure that they are resuscitated well as not being on pressors. So giving that ability to transport right away and then be able to tune up the patient before cardiac cath was a huge win for us. So in 2021, we advanced clinical coordinators to echo training. So we had advanced clinical coordinators, and they are the ones that perform intubation, head of bed, chest tubes, central lines, ART lines. They are the charge in the ICU, and they are in the back of the ambulances as well. We transport our own donors here to IDN. So we've currently now had 4 years of training, of echo training with CompuMed and that partnership. In each class, we've done 6 ACCs, or Advanced Clinical Coordinators. So there's a didactic portion and a hands-on. We do have that as our yearly budget, just to be able to bring new ACCs on and have that training. And there's a feedback phase in that initial phase of those echoes that are submitted, which is extremely helpful for our staff so that they, again, something new, a new skill that people go, year, 2 years to be able to learn. They are learning very quickly in these sessions, which just also proves to the point of the education that is happening through CompuMed and the physicians and the staff that they're able to provide that education. So there's a feedback phase of being able to send those echoes in, and then they get that update and be able to re-echo or get feedback on their windows and things like that. So it's an extremely efficient process education-wise, and also a lot of feedback right afterwards so that they could even practice and send in so many educational type of echoes, just if we have downtime to be able to practice. This is actually, so it's a 5-day intense training. We actually have a lot of our staff here in the organization that's even outside of Oregon sign up to be people that are getting echoes performed on them. And so they're usually expecting that, one time a year for us to be able to put the word out for everyone to sign up. So we have great participation, and here's a couple of pictures of some of our ACCs and their certificate that they get at the end of this. We do have the Vivid IQ is what we currently use. Those are portable devices as well. The only thing that we don't perform here in-house is we do call the Ascension physicians for performing our TEEs when we hook that up to Echo. There is an Echo AI analysis that averages about 1 to 2 minutes of processing. It's something that we're starting to work through. And talking about serial echoes, that is something that we do often here at IDN, because sometimes you have to give the heart time. And, we're willing to do that and do serial echoes. It's something that we're not able to necessarily do in the hospital just because of the task that it takes and the staffing that it takes to be able to do that. So then in 2023, we really started with a hospital direct connect. And so it became very evident that we needed to lessen the burden on some of our hospital partners at the point of trying to find a disc, trying to then get a disc of the CT, cardiac cath, whatever diagnostics it is, trying to then give us that disc, a DICOM image, and then being able to upload, all of those things. So this really helped with not having the hassle of doing that. And we really started with our top donor hospitals, and we, put this out to our staff at first, just in case there were questions initially. But I will tell you that CompuMed met with our hospital services and met with each hospital to be able to take them through the process. And on the back end, they could already see what utilization they were using for diagnostics at each hospital and working with those partners behind the scenes. So, as you look through that, there's a lot of, like I said, it eliminates those burning of the CDs to be able to get the DICOM images. It reduces time to allocation because it's within minutes, seconds, instead of waiting for someone to come in and make a disc and then run it to us. And then we're as you most know as well, new computers don't have discs in computers anymore. So then also having to have a separate disc to be able to read that for our computers takes a lot of time, as well. So these are our top 17 donor hospitals in Indiana, and they're all on Direct Connect. So now that we know when we're going into these hospitals and hospital systems, there's nothing that we need to be asking for, and they're just automatically uploading that so that we have a PowerShare link. So as far as CompuMed stats, over 1,000 studies just in the past 3 years that we have been able to partner with CompuMed in order to give a link to those transplant surgeons or coordinators that are evaluating for our organs being transplanted. And our turnaround times actually are really well within 30 minutes, 34% of the time, 60 minutes within 70% of the time, and 120 minutes within 99.5% of the time. And knowing that not all these that we need are stat, and so there's a lot that we are actually just going with 120 minutes, and they're meeting that mark every single time. And then as far as upload time, so as we talked about with the DCU, once that diagnostic is finished, before we even have a chance to get the patient back over to the cot, the upload is already done. It's already in there and ready to go. Hospital-wise and all those direct connects that you just previously saw, 5 minutes of time compared to calling someone in, someone trying to find the disc, and really up to 1 to 4 hours in trying to get that to get that out and get that DICOM image for a link. So it's really taken down our time frame of where we are and what we've been able to get accomplished with CompuMed and become more and more efficient. So some of the differentiators, APIs, they're really able to quickly share images, reports. Data is really safe, it's secure, it's in a cloud environment. Also able to show the work. So reporting around, drilling down to see where that information is coming from, verifying that, validating that, but be able to get reports, whenever we need that. And then a platform really to build on APIs and run in the same backend, which is also very highly secure. And then really laser focused on new ways. And what I want to wrap up with this piece is that, new ways to leverage technology to improve the processes and provide additional resources. Like I said, from the beginning of the very first meeting that we had here at IDN, the common theme and partnership with CompuMed the entire time has been really to figure out where our pain points are, figure out how we can get more organs transplanted. What is the timetable? What is taking the time? What is not efficient right now? And how can they help to make it efficient? And I will say that this team that we have worked with have consistently done this throughout the years of asking us what we need and then finding solutions to be able to help move us forward and be more innovative together. So that is all that I have presentation wise. If you have any questions, I'm all ready.
So, my team knows this. I tend to get very emotional because we see behind the scenes don't always get all of this impact. So honestly, can't wait to share this with our team, the whole CompuMed team, so they see how they are actually helping not just Indiana Donor Network, but the community help save more lives. So Sherry, this is fantastic. Thank you. In full disclosure, I didn't see any of this up front, so everybody knows. So it was the first time. There are a couple questions that were sent in. So one of them is, this is a great question I always like. How do you handle discrepancies in interpretation between hospital and CompuMed?
So we've actually had that a couple of different times, honestly. And so what we have done in those situations is looked at what the discrepancy was first. I think that's the first thing you have to do, because I think that, in donor hospitals, a lot of times we don't, we're having just one entity read that. And so everything from our DCU is only going to CompuMed. It's not going to anyone else. It may be looked at by one of our pulmonary critical care physicians, but the ultimate read is from CompuMed. Donor hospital, a lot of those are already automatically read through radiology, but we do have some that we do reread. And those have been on rereading basically because of safety. Now, the ones that we have not been a reread, and it's because we're having CompuMed read and then hours later, we do compare those. We do upload both. I think what we have to do is always provide the information from both. And you have to let the transplant center surgeon decide. They have the access to the actual diagnostics. They can look at it themselves. They could send it to radiology at their center and have them look at it as well. The rereads have been because there have been some type of nodule or something like that. And so we've asked for CompuMed to take a look at it as well. And kind of going back to the donor hospitals where they don't read as much as what maybe some of the bigger centers do, we want to just make sure that we are safe. And so even if we have a read that is different, and we will look at it with our medical direction, but we will always upload both so that it is able to be seen. The other part of that, like I said, is the link is there so that the surgeons and whoever they would like to consult, they can actually see the diagnostics. And I think that that's paramount, even besides some of the read that you get. I don't know if that helps, but.
Absolutely. And I know that we've worked together too, where we've had some QA where we then will have our multiple doctors read them and compare, we have them blind read it and then we compare it and then we review it back with you and your clinical team. So thanks. Here's another question. Have you seen any improvement from the past to now and how the transplant centers are making decisions with these technologies and methods?
I would, and I would also say too, we have a very good relationship with our local transplant centers, and so being able to have a link and them actually look at everything themselves as well is very, very helpful. And so I have seen a greater satisfaction and with being able to have that visibility, a greater confidence and ease to be able to accept that organ because they're able to see everything.
That's great to hear that. It is about making it easy for them because, as you know, they're on the fly in the middle of the night, sometimes looking at their phones, right? So another question, how do you differentiate pediatric donor management?
So we have guidelines, and we call them guidelines because our people are very autonomous that are taking care of our donors. And so pediatric donor management, we actually work with Riley Children's Hospital and some of the physicians there working through all of those, the management guidelines when it comes to their specialty. So they are helpful with us in that, and that's how we run our guidelines. In-house, we bring any pediatric patient that's 50 kilos and over. As it stands right now, we'll probably continue to lower that because our equipment does go down to an infant. But as far as, reading and all of those things, as far as diagnostics, it's very similar, and it is spelled out in our guidelines.
This one, I'm just going to read it as is. I think you'll understand it a little bit better than me. Any suggestions on data to focus on when working to convince the transplant that, that it's worth it up front, and also for your company, like, was there anything that you had to convince your management to working with CompuMed on the costs?
No, I really didn't. I think that we're pretty innovative here and pushing forward and making sure that we're honestly are trying to do things before we're asked to do them, meaning before it is required as a transplant community and an OPO community. So I think these are very important to ensure that we have safety above all else for organs. And I think without having some of these things and without having secure links and links that will expire and that we can set those forth that once they're looked at in a certain amount of time, that's no longer available, and all of those gives you a little bit more control of exactly what is out there and what exactly you can ensure that is being seen. So really, with putting safety paramount and getting more organs transplanted and reducing those timeframes, I think those last few slides of being able to reduce the timeframes to be able to upload those, because you have a delay in allocation, then the sooner you can allocate in some instances, the better outcomes you're going to have of having those organs accepted. So I think having all of those things and lining that up, with our leadership here, it was not something that was even questioned after that.
Right. Okay. One more question, and then we're getting close. So do you have any reduction? I'm sorry, let me restate that. Do you have some approximate reduction in the actual case times that you can attribute to the different methods and tactics you've talked about in here?
So we do have a Power BI dashboard that goes through, we measure each time. So authorization to on-site, on-site to start of allocation timeframe, to enter OR, and so forth. And we have seen those things fluctuate over the years of being able to start this and looking at some of that allocation time. And then we saw allocation time kind of grow a little bit as we got better. So some of it actually increased. Our time on site has actually increased from where it is in the past, probably 5+ years, because we have grown as a company to say we're exhausting lists. We're going to prone for 12 hours. We're going to do all of these things that in the past we were not doing. So our allocation time has actually increased. But I think it would be a lot more if we didn't have the direct connects and the time that is the efficiency pieces that are able to be taken care of with CompuMed, where we can now focus on donor management and actually hands-on taking care of the donor and not worrying about the other pieces of that.
Right. Well, your metrics are say it all, and you can tell the hard work at Indiana Donor Network too. And we value the partnership with you and the entire team so much, and look forward to continuing it too. So we'll go ahead and wrap it up here, unless there's any final words, Sherry, and we appreciate all of your time.
I don't think so. I appreciate you guys as well.
Thank you.